yesterday, a child.
Welcome to Gracefully Grading. I'm your host, Attorney Henry Gornbein. Today on Gracefully Grading, I'm pleased to welcome back as my guest General Surgeon Scott Laker. Scott and I did a show earlier on bariatric surgery, which is kind of an innovative and important area, and we're going to now transition from bariatric surgery to general surgical procedures that people face, especially as they're gracefully graying. Scott, welcome back to Gracefully Graying.
Thanks for having me again.
I think I told you earlier, at lunch I was with two friends who are retired doctors, and I was mentioning who my guest was and talked about bariatric surgery, and they said they had heard that bariatric surgery is a cure for, I guess, type 2 diabetes. Would you expound on that a little?
Yeah, it's there's a lot of truth to that people with type 2 diabetes, or non-insulin dependent diabetes is another way to call it, is it has a very profound effect. An effect that we see even before there's any identifiable weight loss. So it's not just simply losing the weight and there's an improvement in diabetes, but this is a metabolic process that we're not entirely certain exactly how it works, but it happens very quickly and very profoundly. And so a lot of patients who come in, I would say most patients who come in on metformin, on any number of non-insulin medications, will leave the hospital after a 2-day stay without any of those medications. So there's definitely a known effect, and it's been known for a long time, at least in bariatric medicine. But it's nice to know that for some individuals it's still, it's a new discovery. Every year it comes up as a topic in the news, but we've known it for a long time.
But you're not fully sure as to why.
Well, initially it was thought, because we already knew that there's a mechanism as we lose weight, our sensitivity to insulin improves. But what we weren't really able to explain is that why do we see blood sugars normalize while they're in the hospital? Most of the time, when we have a patient with diabetes in the hospital after surgery, we're doing finger sticks and checking their blood glucose, usually around every 8 hours or so, sometimes every 6 hours. And it's really remarkable to see somebody whose blood sugars average in the low 200s, drop to below 110 before they're leaving. And this is before there's any real significant weight loss. There's some theories that there's a change in certain hormones or certain proteins released by the gut hormones called incretins.
And that's triggered by the surgery almost immediately?
Yeah. It's the way the GI tract is rerouted seems to have a really powerful effect and potentiates these incretins, things like GLP-1 and PPYY, and there's a number of other proteins and hormones that were not even known when I was in medical school that are now becoming very popular in research and really opening up a lot of avenues for the non-surgical management of diabetes. So I think bariatric surgery has probably helped improve our understanding of type 2 diabetes in the last 30 years than we've ever, really seen in such a short period.
Now, Scott, you do bariatric surgery, and we spent a good deal of time on that, but you're also a general surgeon. Mm-hmm. So when talking about general surgery, especially amongst those of us who are, quote, gracefully graying, 50 and over, or with aging parents, what are the most common surgeries that you see? And we're going to deal with several and go through them one by one.
People ask me all the time, what does a general surgeon mean? It's unfortunate that there's really nothing descriptive of a general surgery, but it used to be that general surgeons did everything from vascular surgery, arteries and veins, to thoracic surgery, lung surgery, and abdominal surgery, including thyroid and parathyroid. So it was a very broad group of things that general surgeons were capable of doing. And over the years, as people have specialized, and now there are vascular surgeons and thoracic surgeons and endocrine surgeons, general surgery really encompasses things that are mostly within the abdominal cavity.
So let's start, first of all, common type of surgery as we're aging are hernias.
Sure.
So let's talk about that.
So hernias are incredibly common. More common males than they are in females, but still very common in both genders. And they've been known and described for centuries, and some of the earliest sculptures and ancient texts describe or depict hernias. So it's been something that men and women have been suffering and been treated for many, many centuries. I don't know if you know, the Vesuvian Man is that famous anatomical drawing by Leonardo da Vinci.
Right.
And it recently came up at a hernia conference that it may be that the Vesuvian Man, which is supposed to be a depiction of a person in its
spread out like
exactly,
this.
in the most perfect form. If you look closely, and I suppose you could argue either way, but there also may be a depiction of a left groin hernia in the Vesuvian Man, and so that was recently a topic of conversation at a hernia meeting. So it's been described in sculpture and in art and all sorts of different forms for many, many, many centuries.
What is a hernia exactly?
So a hernia is really, I think that the easiest way to describe it is it's an opening somewhere where something moves from inside of that opening to outside of the opening. And so classically, people think of hernias usually around the navel, which are called umbilical hernias, or in the groin, which are called inguinal hernias. It's really something from inside of the abdominal cavity moving through an opening of the abdominal wall and to underneath the skin, or really large hernias in the groin can extend down into the scrotum.
And why is it more common as we're aging?
Well, there's tissue degradation, just natural wear and tear of our tissues. We get older, and our ability to kind of self-repair tissue probably degrades with time. And so tissue naturally gets weaker as we age. But also as people get older, people tend to go and see doctors more frequently and have had more years under their belt to develop some of these acquired conditions. But having said that, the majority of groin hernias are still something that we're born with, and that can get larger and more symptomatic as we get older.
You know, Scott, I was born with a hernia, and it was in my lower abdomen, and we ignored it for many, many years, and finally, it's got to be maybe 8-10 years ago, finally my primary care physician just said, time to do something, and I had her taken care of.
Yeah.
So, and why don't you explain to us exactly what the surgical procedure is when you're dealing with a hernia?
Yeah, so the surgical procedures are really dependent on the location of the hernia, and so depending on where it is, you can have hernias, in the lower abdomen, in the groin, and then around the navel, and then you can have hernias in the abdominal wall related to previous incisions. Those are called incisional hernias. And then you can have hernias where things from inside the abdomen are sliding into the chest, and those are typically hiatal hernias, where we see it a lot in people who are overweight or obese, where the stomach is forced because of high pressures in the abdominal cavity through a natural opening in the diaphragm, and the stomach slides further and further into the chest. A lot of people will have reflux that have hiatal hernias. So the management is totally dependent on the location. But to answer your question, the most common hernia in males is a groin hernia and an inguinal hernia. And there's lots of different ways that these can be repaired. There's the traditional open approach, where we make an incision over the groin and identify the area of weakness or the opening of the abdominal wall and close it. It can be closed with just sutures, that's called the tissue repair, or we use something to reinforce called mesh. And then there's the laparoscopic approach, which allows us to repair these hernias from inside of the abdominal cavity, or in some cases in between layers of the abdominal wall. And so there's lots of different approaches.
You often hear of hernias being caused by someone doing some exertion, perhaps lifting too much or doing something he or she shouldn't. Is that a common cause as well?
It's probably less common than people give it credit for. Oftentimes patients will come to me and they'll say, I know exactly when I did this, when I developed this hernia, I was gardening, or I was helping, a friend or family move something in the backyard, and I felt a pop, and I had this hernia. There's usually an event that draws a person's attention to it, but the majority of these people that notice these hernias after an exertion still have something that they were born with, and that over time this enlarges, and then something that they do forcefully pushes something from inside the abdominal cavity through that opening and into the groin. And from an operative standpoint, you can tell which ones we're born with and which ones we acquire, and the majority of these ones that people are born with. So it's tearing the abdominal wall is not something that's terribly common. It's actually quite uncommon. So most of the time people have had hernias, didn't notice it for a long time, had an event, and then it becomes more obvious that there's something wrong.
Scott, another area that you deal with are gallbladders.
Yeah.
Tell us about that.
Gallbladders are a pretty common issue. I see it with a lot of frequency, and it is something that you tend to see as people age. Gallstones can occur in anybody. They're usually in people who are middle age or older, but they can form in younger people. Women supposedly are a higher risk because of hormonal changes. It's associated with pregnancy. There's probably a strong connection between diet and gallstones. It seems that more westernized diets tend to have a higher incidence of gallstones. There's also a familial or genetic predisposition to gallstones, so you can see them clustered in families. Gallstones are the most common reason why somebody would present to the emergency room or to the doctors with gallbladder issues. And gallstones are very prevalent in the aging population.
What treatment do you do?
Well, it depends on the way gallstones are identified. Sometimes patients will be sent to me who have had imaging of some sort, a CT scan, for a reason unrelated to what is perceived as gallbladder pain, and they're incidentally found. In a lot of those cases, we can safely watch. There are a lot of people walking around with gallstones that don't know they have them. There was an autopsy report that came out that about 10% of patients that underwent autopsy had gallstones. The overwhelming majority were totally asymptomatic, or if they were symptomatic, it was very mild or minor, subclinical. But when gallstones are symptomatic, they can be really, really painful and cause a lot of distress to the patient. And then there's a pretty strong indication to remove the gallbladder.
And you remove the gallbladder, does that mean, first of all, how long does that take as far as recovery and the surgical procedure itself?
So the surgical procedure really is a laparoscopic procedure at this point. It's one of the few operations that gold standard is considered laparoscopic. Things are still a bit slow to catch on, even though we're moving to a more minimally invasive treatment strategy. That's still, when we look at gold standards in textbooks and things like that, the open is still the gold standard, except for gallbladder. This is, traditionally had been done through a large right upper abdominal incision that would potentially leave a patient in the hospital for a week or so, and with a really lengthy recovery. When we do it laparoscopically, the majority of time it can be done with 4 small incisions. The procedure, when done electively, can take a half an hour, and patients can bounce back pretty quickly from that. But having said that, patients are all very different, and most people, I would say, to feel like they're totally back to themselves about 3 to 4 weeks.
And how important is age regarding these issues as far as gallbladder surgery and gallstones?
Well, the older we get, certainly the more chronic these gallbladder conditions can be. Some of the more frightening patients that I've had to take care of are what I call the VA gallbladder. I've spent a lot of time at the VA, and these are a tough group of guys. And some of these guys are in their 70s and their 80s who have put up with a lot of episodes of abdominal pain, probably thought it was indigestion, something that they ate, when in fact it was just episodes of gallbladder inflammation. And some of these can be really inflamed and really plastered in there. And so the longer you have gallstones, the more symptomatic you've been, the more challenging it can be. But I don't think that being old is a risk factor for having a bad outcome.
What about other stomach issues?
There's no shortage of stomach issues. Thankfully, the majority of them are not surgical. Still, some of the most common reasons that people have, stomach issues is diet. Most diets, a lot of diets are based off of highly processed foods, fried foods, fatty foods, and these things can lead to gastrointestinal issues. That's the most common reason that people might have abdominal pain, but there's lots of other reasons. I've found that in the elderly population, it's still low incidence, but there's peptic ulcer disease is something that we do see with some frequency. This used to be a very common operative emergency, ulcers with perforation or bleeding. We see it much less frequently now because of all these antacids that people are prescribed. But a lot of the older population are on things like Motrin or a baby aspirin, and these non-steroidal anti-inflammatories can really reduce the protective mechanisms of the stomach. And so when I do see a perforated ulcer, it's usually in an older person who's on these chronic NSAIDs.
And what's the procedure that you do with regard to that?
It's historically, this was a big operation. That part of the stomach would be removed, and that we would divide a couple of nerves that move down onto the stomach and stimulate the secretion of acid. And those were some big operations. And in the 60s, the 70s, that's what general surgeons did a lot of. That's really been replaced by weight loss surgery in my generation because of these things like Protonix and Nexium and all these really powerful medications that suppress acid production. So usually when somebody comes in with either a bleed from an ulcer, it can be dealt with through endoscopy, like an EGD, where the scope is placed into the stomach and things can be clipped. And perforations can typically be managed by sewing the perforation closed and using surrounding fat that's usually around the area to kind of patch it. And the need for doing these vagotomies or these ulcer reducing procedures has really been kind of pushed to the wayside because the medications are so effective.
What about the appendectomies? Do you see a lot of those? Do you do a lot of those, I should say?
Yeah. You can't be a general surgeon that takes calls and somehow avoid appendectomies. They're obviously more common in the younger age group. When I had mine taken out when I was 17 or 18.
I was 19 when mine was taken out.
So it certainly it's associated with the younger population, but we see this with real frequency in the aging population. And although historically it was taught to us that so an elderly person that presents with appendicitis, it's colon cancer or a GI cancer until proven otherwise. But I think as we are starting to really get a better understanding of what it's like to manage patients in their 70s and their 80s, that we're seeing disease processes that we didn't think occurred in these age groups that definitely occur. So appendicitis is still something very real in the aging population.
What about bleeding issues? Are there other areas of bleeding that you deal with besides, ulcers? And
one of the biggest issues in the aging population, this is really across the world, is the medications that most of our patients a lot of our elderly patients are on for things like atrial fibrillation. People have historically been placed on an anticoagulant. It's been Coumadin for several decades, and now there are lots of other medications like Eliquis and Effient and all of these other medications, and people that have had stents who are on Plavix. These are not bleeding issues necessarily related to surgery, but issues that we can, may have to contend with when people come in the middle of the night or even electively for general abdominal surgery. But bleeding issues, I don't know if I'm answering your question, bleeding issues from a surgical perspective, aside from ulcers, Diverticular disease of the colon is probably the most common cause for a GI bleed in most people as they get older, if you take away things like hemorrhoids and those really benign things.
Scott, what about pancreatitis?
Pancreatitis is seen with real frequency. The most common cause of pancreatitis are from gallstones. The gallbladder and the pancreatic duct share a common connection where they empty in the first part of the small intestine. And gallstones that make their way out of the gallbladder and through the common bile duct or the main bile duct, and most of the time they're passed into the small intestine, they passed out in their stools, can create inflammation of the pancreas. And gallstone pancreatitis can be a really, really bad situation. Alcohol is something that we see that's clearly associated with pancreatitis. And there are certain medications. Some are pretty common medications that people take that it's a low incidence of pancreatitis, but we do see it. And then there are high triglycerides is another cause for really profound pancreatitis.
What about pancreatic cancer? Do you deal with that surgically?
I do not deal with it surgically.
Okay.
I know some people who do, and when I do come across somebody that needs it, there's a few people in my Rolodex that I contact. That's a very complex and involved operation, but there's some really very skilled people in the metro area that can do these operations.
What about arteriosclerosis and atrial fibrillation? If I'm mispronouncing it, I apologize.
You're doing good. Yeah. That's very prevalent in the population as they get older, and from a surgical standpoint, this is what a lot of vascular surgery and cardiac surgery and now interventional cardiology is dealing with. Things that we used to do, arterial bypasses to bypass around blocked arteries either in the legs or in the heart, are now being stented or balloon angioplasted. And there are lots of new novel procedures that other types of surgeons are using to kind of contend with that. Again, in general surgery, a lot of our patients, over the age of 60 or 70 have atherosclerosis, and this has to be kind of taken into account when we're managing these patients both electively and emergently for operations.
You came out of surgery today. What were the surgeries that you did?
So today I did a lipoma, which is a very common condition. A lipoma is a benign fatty growth, and they can really occur anywhere on the body. I have yet to see them on the palms of the hands or the soles of the feet, but I think I've encountered them pretty much in every other part of the body. We don't know why people develop them, but they're uniformly benign. And
how large are they before you would get involved?
It depends on the person. It depends on the location. Somebody who has one on their back and they're leaning up against the chair might be bothered by it, versus somebody who's got one on their shoulder, which, I've seen patients wait years and years and wait until the lipoma is about the size of a baseball before they decide to do anything. And then there are other people who are bothered by just the idea that something is there that shouldn't be there, and we take them out when they're much smaller. But they're really a very common thing, and not one that I tell my patients to spend any real time worrying about. These are not things that degenerate into cancers. The other two cases were abdominal wall hernias and groin hernias.
And what are the majority of your surgical procedures?
Hernias probably make up about 60% of what I do, and of that 60%, probably about 50 to 60% are groin hernias, and the remainder are either umbilical or incisional hernias. Incisional hernias are kind of a different kettle of fish, in that the physiology, at least the pathophysiology, is a little bit different. That these are real healing issues. There can be technical issues that lead to hernias, but these are collagen issues and wound healing issues, connective tissue issues, which lead to why some people after an abdominal incision will develop a hernia and others will not. There's also a technical component to it. But these are becoming much more complicated as the types of procedures that we do for other things like cancer, pancreatic cancer, colon cancer, have historically been done through large midline incisions. These are the patients that down the road may need further surgery to fix abdominal wall defects.
And you're involved with these, like you may have a surgeon who's dealing with, you know, a malignancy, and then if there are problems that occur later, then often these patients come to you.
Yeah, so a big part of my practice is what we call AWR, abdominal wall reconstruction, and it's really becoming kind of its own specialty. People who have focused or spent their careers on hernia surgery have started to kind of branch and do focus on hernia repairs. The treatment for hernias has changed tremendously. Even since I was a medical school or a resident, I've seen more change in the way we manage hernias than in almost all other facets of what I do in general surgery. So that's been really exciting to watch. There's been a lot of movement from these big open complex abdominal wall reconstructions to either laparoscopic or robotic repairs. And just the way we're repairing these things is really very different.
So technology is really changing in your area, and I imagine you're on the cutting edge on a lot of these things, for lack of a better.
I try to stay on top of what's going on, and believe it or not, the most recent change in abdominal wall reconstruction wasn't really a technological change as it was in the last 15 years of having a different understanding of the anatomy of the abdominal wall, and I think it's surprising when we think about it. You know, the abdominal wall hasn't changed in the last, several hundred years, but we recently, thanks to a real pioneer, Yuri Nowitzki, identified a very novel way to work within the layers of the abdominal wall. And so just our understanding of the anatomy in the recent past has changed the way we approach these things. So it wasn't a real technological change, it was an anatomical understanding that took hundreds of years to really appreciate.
Fascinating. We're down to less than a minute. What are some takeaways you can leave with our viewers before we sign off?
Not all abdominal pain is a surgical emergency. A lot of people call me up. They're in a panic that either somebody in their family or themselves is, they're frightened that they've got appendicitis or an ulcer or something. Thankfully, the majority of abdominal pains are not related to something that needs to be managed surgically. As far as hernias go, there's a lot of dogma as far as what should I do and shouldn't I do if I have a hernia. And what I tell all my patients, and I think the general public should know, live your life. Don't limit yourself physically from doing things that you enjoy if you do have a hernia. If it's interfering or causing pain during these activities, that's a different story. But a lot of people can go about their business and enjoy an active life with hernias. And so I think that's kind of a paradigm shift over what we've told people over the previous 30, 40 years.
Scott Laker, I want to thank you so much for being my guest on Gracefully Graying. And I want to thank you for watching Gracefully Graying.